Welcome to the Universal Expert Studio. I am Dr. Hany Hafez, Professor of Nephrology at Cairo University and President of the Egyptian Society of Nephrology and Transplantation. I am quite privileged to have today Professor Tarek El Baz, Professor of Nephrology at Al-Azhar University, past President of the Egyptian Society of Nephrology and Transplantation, and actual President of the Arab Society of Nephrology and Transplantation. Welcome, Dr. Tarek. And also I have Dr. Magdy Sharkawy, Professor of Nephrology at Ain Shams University. Professor Magdy is actually the chair also of the hemodialysis in the Egyptian Society of Nephrology and Transplantation. And we'll be speaking about a very important topic, endothelial dysfunction, after the break. Let's go to the break first. We came back and now we will ask Professor Tarek El Baz to address this very important topic of endothelial dysfunction. Professor Tarek, please.
Thank you very much. I would like to start by saying that endothelial dysfunction has evolved over the years and has become a very, very important issue in health, particularly related to cardiovascular morbidity. The endothelium is not regarded anymore as just a lining for the conduit of the blood, whether in the blood vessels itself or the lymph, but rather an organ that has a lot of secretory functions and endocrinal functions, and it is responsible about many disease areas and interacts with the microbiome and with a lot of metabolic aspects occurring in various disease areas.
Thank you very much. And I would like to ask you, Professor Tarek, how is endothelial dysfunction linked to the cardiovascular morbidity, especially in the chronic kidney disease population?
Okay. We understand that chronic kidney disease has a particular peculiarity when it comes to the endothelium, because these patients most often have already the traditional risk factors, which are obesity, diabetes, hypertension, dyslipidemia, physical inactivity, and maybe smoking, plus particular risk factors related to the uremic milieu itself, such as vascular calcification related to hyperphosphatemia, hypomagnesemia, as well as excess in the serum PTH. So the vascular endothelium in CKD really reflects a much poorer state than the general population with similar diseases due to these added factors.
So now we will go for a break and we will come back after soon. We came back and we asked Professor Tarek to continue his answer on this endothelial dysfunction linking to cardiovascular morbidity. Please, Dr. Tarek.
Yes, it all comes back to nitric oxide. Nitric oxide levels are definitely lower in patients with CKD due to the dysfunction that is occurring within the endothelial walls, and it is known that nitric oxide is important for the vasodilation and hence the perfusion of organs. And when this hormone is not present, this function also is not present. How can we increase the nitric oxide levels? And this is an important thing. Looking at the slide, you can see that the nitric acid is related to levels of L-arginine, which is a semi-essential amino acids. The L-arginine is present and abundant in legumes and meats and dairy products, which are already the patient is deprived of. So even if you are giving the patient intravenously L-arginine, the response to L-arginine in the endothelium to form nitric oxide by nitric oxide synthase is very poor and defective. But the new notion related to how can we increase nitric oxide to abolish or overcome the vasoconstriction related to the endothelial dysfunction is by simply exercise and maintaining aerobic exercises. And this is quite a new insight in treating nitric oxide deficiency. Simply by aerobic exercise, it improves the formation of nitric oxide synthase, which will be able to work on L-arginine and form abundant amounts of nitric oxide to abolish the vasoconstriction. Now, this pathway is also mediated by the cationic amino acid transporter 1 and protein kinase C alpha, which are also activated and enhanced in their pathway and action through the effect of simply aerobic exercise. Aerobic exercise is important because our patients have a cardiopulmonary deficiency, which makes them really vulnerable to cardiovascular morbidity and death. These patients don't have to develop at all end-stage renal disease because most of the time these patients die on the way due to the cardiovascular morbidity. The graph on the left-hand side of the slide shows that mice that were treated both by L-arginine alone did not do much good in relation to the production of nitric oxide, while exercise shows a highly significant difference when these mice were subjected to exercise in the wheel over 6 hours. They did much better and their exercise tolerance was good. Now I'm putting this diagram also to show the relationship between the deficiency occurring in the cardio-respiratory fitness in our patients, which is directly related not only to progression of the heart disease, but also to the kidney disease, which will also progress. And if you do not break this cycle early, meaning that to get a good response to exercise, it should be maintained early. And when you maintain it early, you get the best results, and you have to maintain this exercise workouts all the time with the patient. And when patients were plotted against those living a sedentary life, definitely the ones that were subjected to having aerobic exercise training did much better in relation to the production of nitric oxide. Yes? So looking at this diagram, you can see what is known as the uremic switch. We have terrible accumulation of asymmetric dimethylarginine in our patients, hindering and impairing the transformation or the transport of L-arginine to nitric oxide, and this is known as the uremic switch. Again, simply adopting a physical exercise program in these patients, as has been recently shown, improves this situation. Of course, there are other methods and there are other things that could improve the production of nitric oxides, such as a healthy diet, refraining from smoking, good metabolic control of diabetes, if there is diabetes, as well as the use of antioxidants to get rid of the reactive oxygen species.
Thank you very much, Professor Tarek. We will go now for a break. we are back, and Professor Tarek, please.
Yes, after talking about endothelial dysfunction, I would like to ask Professor Magdy Sharkawy about how is it possible to assess this endothelial dysfunction? Is there a way, is there a method for that?
Yes. There is two pathways to measure the endothelial dysfunction. You have an invasive pathway, which we don't prefer, and we have a non-invasive pathway. The non-invasive include using the sphygmomanometer to increase the systolic pressure in the arm, 50 millimeter mercury above systolic pressure, and we'll keep it for a few minutes. Then we release the pressure. This will lead to flush of nitric oxide, and if the endothelial is healthy, we can detect it by either measuring flow-mediated dilatation in large vessels like the radial artery by electrodes. And this will tell us if there is enough response to this nitric oxide or not. Or the much easier way is to use the tonometry, which is using just the index finger, and we can measure the peripheral arterial tonometry, and we can, by computer, detect the response in the vessels. The two invasive technique, one of them is using quantitative coronary angiography, which is very much invasive, or the IVUS, which is intravascular ultrasonography. Again, it is invasive, but it tells us exactly the response in the vessels directly. Or we can measure the endothelial progenitor cells. And these are the methods we can use, because measuring nitric oxide, I think it's not practical. So, but I have a question for you, Professor Tarek. So, can you brief us more on regarding the endothelial dysfunction? Is there an interventions to improve it? Is there any new event in the field of endothelial dysfunction?
Okay, yes, there is actually a new insights related to endothelial dysfunction, and this is known as the endothelial aging or endothelial vascular aging. For years and years, physicians have been trying to fight disease and fight death, as you can see in this slide. And maybe this figure also represents aging. We have a dream of delaying aging as much as we can, not because we don't regard aging as the way we look, definitely, but we look at aging as aging of the organs, metabolic diseases, Alzheimer, hypothyroidism. This is aging, and these are the things we want to get rid of. Now, looking at this slide may simplify or explain what I want to say related to endothelial vascular aging, which is EVA. Even the name EVA is something denoting being young. We have two problems leading to the endothelial vascular aging, particularly in our patients, the chronic kidney disease patients, is the endothelial senescence, which I will come to, and endothelial chronic inflammation, also known as inflammaging, related to this sterile inflammation that's going on within the vessel wall as the patient age and as the vessels age. Now, this endothelial inflammaging is related to various points, some of which are seen on the slide, such as telomere attrition. And the telomere, once starts to shorten, the DNA may be exposed, and once the DNA exposed, it is damaged, and this is how endothelial senescence does happen. Other factors are also the low phenytoin levels, the oxidative stress, the decreased clotho, and clotho has been shown to be associated with aging since its discovery, together with the microbe dysbiosis. Now, what is happening in the endothelial walls in cases of chronic kidney disease? We have a state of endothelial senescence. Senescence, which has been discovered since 50 years, means that the cells become in a state of, if you allow me to say, they become zombie cells. They are zombified. They are not dead, yet they are not functioning properly. And as so, don't think that the zombified senescent cells innocent and benign cells. No, they are secreting a lot of pro-inflammatory mediators such as interleukin-1, interleukin-6, TNF-alpha, and all of these mediators and others are definitely leading to a lot of damage to the healthy cells surrounding the senescent cells. Yet, senescence is a physiological phenomenon. The body tries to overcome the oncogenesis and the oncogenes by having the cells going into senescence. Later on, they are either cleared by the immune system or they go into apoptosis. The peculiarity again about the endothelial vascular aging in our CKD patients is the occurrence of the medial vascular calcification. And the medial vascular calcification is a state that does precede the occurrence of the atherosclerosis, which is the ultimate point of damage occurring to the endothelium. Again, looking at this graph, maybe it explains what I have been saying related to the factors that lead to the vascular smooth muscle cell damage and the DNA damage and the exposure of the DNA once the telomere has shortened. We have various pathways after that for the senolytic, for the senescent cells, whether they are going to stay in a state of senescence, producing the unwanted mediators, or will be overcome by the process of apoptosis.
This very interesting update about delaying aging. So could we delay aging in a way, Professor Tarek, according to this senescent theory?
Since we understand now that the dysfunction is a state of senescence affecting the endothelial cells, yes, there are trials now with what is known as senotherapy, and senotherapy would go into these three channels, whether you try to prevent the occurrence of senescence by approaching the reactive oxygen species, trying to improve the internal milieu of the uremic patients by improving the microbiome. Also, you may have another pathway, which is the senescent cell anti-apoptotic pathway. You would enhance the occurrence of apoptosis to get rid of the senotherapy, or you may like to use the senolytics, which are a new group of drugs. Mind you, metformin, which I have been talking about earlier, mentioning its value in preventing aging or ameliorating aging, is doing this through the senescent cell anti-apoptotic pathway. But we have also a new vision about senolytics, which are drugs that are working on the senescent cell anti-apoptotic pathway. And this is the last slide I want to show you to sum up what I have been just saying, or to conclude what I have been saying. Whether you are going to reduce the stimuli and stress, or prefer to inhibit the pro-inflammatory signaling from these sickly cells, the senescent cells, you may be achieving this using glucocorticoids, rapamycin or metformin or JAK inhibitors, and the recent drugs available now to target the clearance of the senescent cells by senescent cell anti-apoptotic pathway enhancement. By thus, these drugs will be able to enhance apoptosis and clear the senescent cells right away from the endothelium. And we have various drugs listed here. I will just mention the most important drugs, the dasatinib and quercetin are the most popular drugs now, attaining a lot of work and research, and the list follows, as you can see, various other drugs such as navitoxilax, as well as a recent drug that has been tested in the field of senolytics.
Thank you very much, Professor Tarek. It was a very interesting update about aging and senotherapy, and we hope that these drugs come in the near future and could be helpful for our generation.
Thank you very much. Thank you.
And thank you, Professor Magdy, for being with us. It was a very important topic and discussion, and thank you for the audience to be patient with us all the time. Thank you very much.